She had 1 year international thoracic surgery fellowship training specializing in thoracic surgical oncology and minimally invasive surgery, both in VATS and Da Vinci XI robotic system from Royal Melbourne Hospital, Peter MacCallum Cancer Center. Ladies and gentlemen, Dr. Jesyl Gagto.
Good afternoon, everyone. My name is Jesyl, or as my Australian colleagues like to pronounce it, Jesyl. I'd like to thank PSGS-PALES and PAMITS for this invitation to speak before you all to share my insights on comprehensive thoracic oncology from the Royal Melbourne Hospital and Peter MacCallum Cancer Center in Victoria, Australia. The objective of this lecture is to share my personal experience as a thoracic surgery fellow and to take what we can apply to the local setting. So please lend me a few minutes of your time to take you on a short trip from Melbourne to Manila. Melbourne and Manila have some similarities. In both countries, lung cancer is the signature disease of the specialist thoracic surgeon, and the disease burden is high. As you can see on these graphs, so the green are the incidences of lung cancer, or actually cancers in all parts of the body, while the mortalities are marked red. Australia has more than 13,000 cases of lung cancer per year, and it is the most common cause of cancer death and is the fourth most common cancer by incidence. It disproportionately affects indigenous peoples, lower socioeconomic groups, and the incarcerated population. Similarly, in the Philippines, lung cancer is also the leading cause of cancer mortality at 21.3% and is the second most common cancer by incidence. It also disproportionately affects those from lower socioeconomic status, which is why it is important for us to discuss the coverage of healthcare. Similar to the Philippines, Australia's national health system consists of two overlapping layers of insurance, the public and the private health. Universal health cover, or Medicare as they call it, is funded by the federal government and provides free hospital care in the state-based hospitals and provides a rebate for primary care and specialist consultations and some interventions, while optional private insurance allows choice of specialists and admission to private hospitals. So this is very similar to the setup in the Philippines with PhilHealth and private HMOs. But it's interesting to note that both in the public and private health systems in Australia, they are very sophisticated with good access to high technology interventions. There's practically no disparity between the resources in the public and the private hospitals. And this allows patients to proceed from initial consult to lung cancer diagnosis and surgery with minimal out-of-pocket expenditure. The Pharmaceutical Benefits Scheme of Australia also provides equitable low-cost supply of even the most expensive drugs if they have been approved through an evidence-based process. This includes access to immunotherapy and tyrosine kinase inhibitors for their approved indications. So the Royal Melbourne Hospital is one of Victoria's largest tertiary hospitals with 1,084 bed capacity and 42 ICU beds. Across the road is Peter MacCallum Cancer Center, a part of the Victorian Comprehensive Cancer Network, with 160 inpatient cancer beds and 110 same-day admission beds and a dedicated clinical trials unit. They're connected by bridges and are practically functioning as one hospital. Together, these hospitals have complete complement of the NCCN recommended diagnostic and therapeutic modalities for lung cancer, including low-dose CT scan for screening, FDG and dotatate PET, linear and radial EBUS and EUS with rapid on-site examination, navigational bronchoscopy, CT-guided biopsy, respiratory and cardiac function testing, stereotactic and conventional radiotherapy, surgery, including robotic thoracic surgery, chemotherapy, immunotherapy, targeted biologic agents, palliative and end-of-life care. They even provide services for hospital in the home and voluntary assisted dying or euthanasia. Here are some photos to liven up the room. So around 200 to 300 surgeries for lung cancer each year are done at the Royal Melbourne Hospital and Peter MacCallum Cancer Center, with 16 main operating rooms and 8 operating rooms respectively, and 4 day procedure rooms altogether. All of these surgeries are supervised and attended, if not done by consultant staff themselves. So this ensures operating room efficiency. The photo on the left is Professor Philip Antipa and Professor Gavin Wright performing a complex airway procedure with an Nd:YAG laser. And on the upper left is radial EBUS case. And then the picture on the bottom right is me performing a robotic lobectomy. So even trainees in these institutions are allowed first-hand experience with supervision. Some of the most exciting cases of lung cancer which I experienced were those that caused airway compromise. We even have set up for veno-venous extracorporeal membrane oxygenation so that we don't have to rush while we recanalize our airway and perform rigid bronchoscopy. We also have access to tracheal and bronchial stents for maintenance of airway patency. And during my time, the hospital also acquired a Nd:YAG laser for airway recanalization. So the reason why I'm showing these photos is not just to flex, but also to remind everyone that despite the gap in facilities and equipment available, these are still modest numbers, hospital beds and operating rooms. We also don't have very fancy or experimental setups and equipment. In fact, in PGH, there's 1,334 bed capacity and a dedicated cancer institute. We also have 15 elective major operating rooms. We are slowly acquiring advanced equipment needed to keep up with standards of developed countries. And while there is much to be improved about the quality of care rendered, I think the quantity of cases can be at par, especially when we capitalize on the manpower of the healthcare workforce available here in the Philippines. Malayo pa, pero malayo na. Speaking of manpower, we also have a multidisciplinary team, or MDT as we like to call it. And this is not an alien concept, as mentioned by Dr. Ramos during his opening remarks. In Australia, MDTs are, for most cancers, are commonplace and is the standard of care even for just straightforward cases. MDTs are usually based in the public hospital system but open to attendance by all specialists treating patients in the relevant tumor stream and general practitioners referring patients even from regional areas. So we have referrals from remote sites in Australia that are welcome to be discussed in our MDTs. According to the Victorian Lung Cancer Registry, which covers a population of 6.5 million, 82% of patients with lung cancer were registered to a multidisciplinary team meeting or a tumor board and were discussed. And these MDTs are well attended by the following specialists. So we have diagnostic radiologists and interventional radiologists, a thoracic surgeon, respiratory physician or pulmonologist, nuclear medicine physician, medical and radiation oncologists, pathologists, palliative care physician, and I think the most important of all is a clinical nurse and patient liaison. Lung cancer MDTs are very well established, and in some of the smaller cities and regional areas that don't have access to specialists, it is still made available through telemedicine links. Since MDTs are crucial in directing patient treatment, they are held twice a week, covering approximately 20 to 30 patients in the discussion. This is just for lung. Each subspecialty is represented to ensure all options are considered, and this is a good way to perform checks and balances. And I think the frequency in which we perform the meetings also contributes to the timeliness of the intervention rendered. This is the MDT at the Royal Melbourne Hospital. So the setup is the radiologist is the one who's manning the console. here, and then we have your thoracic surgeons up front. There's a liaison nurse who personally knows all the patients that are to be discussed, and of course other members of the specialist team. This MDT only lasts for about an hour or an hour and a half, but we're able to cover about 20 patients per in that amount of time. Well, this is the Peter MacCallum Cancer Center MDT. So we have one at RMH and one at Peter Mac every week. All cases are monitored and audited as a way of assuring that quality of services are rendered. And quality assurance is done at multiple levels: national, institutional, and departmental. As proposed by some of the thoracic surgeons in Victoria, these are the key quality indicators of lung cancer. So as a thoracic surgery fellow, I was in charge of preparing our quarterly census, which entailed identifying cancer cases that did not meet the following key quality indicators. And this was a good way of identifying points to improve on, not only based on patient outcomes, but also at the textbook or academic level. So all our preoperative lung cancer patients were checked for compliance to the following conditions. Respiratory function testing was done pre-op, PET scan was done pre-op, EBUS or mediastinoscopy was performed for those with an N1 or N2 identified on imaging. Pathological diagnosis is attempted. It doesn't have to be established for as long as it was attempted. The case was discussed in a multidisciplinary setting. Minimally invasive surgery was attempted, except of course if the tumor is more than 4 centimeters, then you have a leeway to go open. Anatomic resection is aimed for, except in cases of minimally invasive adenocarcinoma or if the pulmonary function testing did not permit. R0 resection was done. More than 3 lymph node stations were sampled, except of course in, again, those cases with minimally invasive adenocarcinoma. And guideline appropriate perioperative systemic therapy was done. So all of the patients who do not fulfill more than 7 of these criteria were audited at the end of each quarter. And this was a good way of trying to pinpoint inadequacies in the system. Our outcome measures. So as a high efficiency unit, we also aim for all post-op lung cancer patients to have a length of stay less than 7 days, no complications requiring prolonged admission or reoperation, no unplanned return to theater, no unplanned hospital readmission, and no mortalities within the first 30 days of surgery. During my time, we had an average length of hospital stay of 2.7 days. Our case-specific morbidity rate was at 10 to 12%. This was a bit high because we considered any prolonged admission more than 7 days as a morbidity. 2.6% had to return to theater and mortality rate was at 1%. This is comparable to global standards. At the hospital level, we ensured that the high dependency facility, which had in-room telemetry and specialty trained nurses, was available for post-op patients. As mentioned, MDT meetings were held twice a week, and an adequate volume of surgeries was done to make sure that the surgical staff stayed sharp. A dedicated registrar or fellow was crucial in clinical and academic work. In our unit, we had 1 fellow and 2 registrars, only for thoracic surgery. And as mentioned, all cases were audited. As a level above this quality assurance process, a nationwide database and cancer registry is also available to facilitate better patient care and quality research. Routine collection and monitoring of surgical procedure data underpins best practice and fosters quality improvement. So the ANSTOR, which is the project of 2 of our mentors at RMH, Professor Wright and Professor Antipa, is the Australia and New Zealand Thoracic Clinical Quality Registry, which includes the database of 24 hospitals, all of which perform high-volume thoracic surgery cases. It includes follow-up until 90 days from surgery, and it was the job of the fellows and the registrars to manually input all of this data after each operation. While the Aurora registry even includes a tissue bank, these database and registry systems provided a feedback loop to physicians regarding not just short-term outcomes, but also long-term outcomes and survival of cancer patients, providing the foundation for evidence-based practice. In summary, I think that the disease burden of lung cancer is high in both Australia and the Philippines. And in both countries, survival rates remain low from patients who present late or due to gaps in the treatment system. Australia has a well-established universal healthcare system, and Medicare supports a majority of cancer care costs. They also have a structured cancer care pathway and multidisciplinary care. In contrast, the Philippines has some gaps in the PhilHealth coverage. Actually, even our standard lobectomy cases sometimes exceed the PhilHealth allowance. Thereby, there's some financial toxicity impacting treatment adherence and outcomes for our patient. There is still some significant out-of-pocket expenditure, and there's fragmented delivery of healthcare due to limited access to specialists and facilities. There's also a delayed uptake of new technologies. But despite this, we also have a large healthcare workforce, which more often than not compromises for all of the setbacks. So how is the Australian model? It's a comprehensive thoracic oncology approach, which includes access to specialist consultations, diagnostics and therapeutics, MDT meetings, coordinated care from diagnosis through survivorship or palliation, quality assurance and regular auditing of outcomes, and emphasis on evidence-based practice. And how is it applicable to the Philippines? The Australian model can serve as a blueprint for developing structured thoracic oncology services. And I think the key areas for adaptation can be partnering with private sectors to improve access to innovation, strengthening public health insurance to reduce out-of-pocket costs, building strong referral systems and NDP infrastructure, and enhancing early detection and access to specialist care. In conclusion, despite resource constraints, elements of the Australian approach are achievable and can be emulated in the Philippine context. With political will, investment in health systems, and local adaptation, the Philippines can move toward a more comprehensive, equitable approach to thoracic oncology. After all, patient care should always strive to be comprehensive and holistic. Which brings me to my final point, quality of life. If there's one big thing I've learned from the Australians, it's this. The goal isn't just to add more years to life, it's to add more life to those years. This distinction is crucial. It reminds us that medicine is not just about extending survival, but also about improving the way people live in the time that they have. And that philosophy should not stop with patients. Holistic, compassionate care isn't just something that we give, it's also something that we need, even though we're the doctors. As doctors, we carry a lot, pressure, overtime, emotional weight from patients, and it can be a lot to handle. But when we take care of ourselves and each other, we show up better for our patients. It was refreshing to experience what it feels like when a system values the well-being of both patients and providers. And it was a lot about balance and about being human. And a good reminder that caring for people also includes caring for the people who care. So as we move forward, let's keep this front of mind. Medicine isn't just about extending life, it's about enriching it and enhancing care, which is the topic of our lecture, and it is for everyone who's involved. Thank you for your kind attention, and I hope we can all learn from the Melbourne way. These are my references.
to you, Dr. Gagto, for that very interesting experience. So, for our last speaker, may I invite